The anatomical landmark I will be palpating is the medial malleolus of the talocrural joint, located at the distal end of the tibia, and it is a bony protuberance. I will be performing a goniometric measurement of ankle plantar flexion, and the patient would be seated with the ankle off the table. The fulcrum would be aligned with the lateral malleolus, the stationary arm with the fibula, and the movement arm would be parallel to the fifth metatarsal with the ankle in a neutral position. You would note the starting position on the numbers and then ask the patient to plantar flex and stay parallel with the fifth metatarsal and notice the difference. They should have about 40 degrees. Okay, to perform passive range of motion for ankle dorsiflexion, the patient should be seated with the ankle off the table, the stabilizing hand just proximal to the talocrural joint, and the movement hand cupping the forefoot. You would then actively dorsiflex the patient's foot, and you should expect to feel a hard end feel. Okay, for manual muscle testing of the soleus, you should have the patient seated with the knee bent to eliminate the involvement of the gastroc, and the clinician should be seated to the side of the patient that's being tested with a stabilizing hand just proximal to the talocrural joint and the resistance hand cupping the forefoot. You would then have the patient actively plantar flex the foot, so push, 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 hold, pull, 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 pull. Okay. The special test that I'll be performing is the anterior drawer of the ankle, and you should have the patient seated with the ankle off the table and the clinician seated or standing in front of the patient with the stabilizing hand proximal to the talocrural joint and the movement hand cupping the calcaneus. You would then apply an anterior translation, and you should expect to feel a firm end feel, and it would be a positive test if there's an empty end feel. Okay. The neurological testing I will be doing for the ankle will be for the superficial peroneal nerve, which dermatome is anterior lateral post. Oh shit! And the myotome is eversion, so you would have the patient actively evert the foot. And the most common pulse site for the ankle is the distal pedal pulse. The anatomical landmark that I will be palpating for the humeral ulnar joint is the medial epicondyle, which is the bony protuberance located just medial to the olecranon process on the distal humerus. The goniometric measurement I will be performing on the elbow will be for elbow flexion, and you would have the fulcrum lined up with the lateral epicondyle, the stationary arm parallel with the lateral humerus, and the movement arm parallel with the styloid process of the radius. You would then have the patient actively flex the elbow and follow with the stationary arm. You should be expected to have about 135 degrees of motion. Okay, when performing passive range of motion for elbow flexion, you should have the patient seated with the arm in anatomical position, and the clinician could be seated or standing on the side of the patient that's being tested. The stationary arm should be posterior to the distal end of the humerus, and the movement arm should be posterior to the distal radial ulnar joint. You would then passively flex the patient's elbow, and you would expect to feel a soft end feel. The manual muscle test I will be performing is for the triceps, which you would have the patient seated with the arm in full flexion, with the clinician next to the patient on the side being tested. The stabilizing hand will be on the anterior distal humerus, and the resistance hand will be on the posterior radial ulnar joint. You then have the patient actively extend the elbow and then resist being pushed back into flexion. The special test I will be performing for the elbow is Tinel sign, which is most commonly used to diagnose cubital tunnel syndrome. To perform this test, you would have the patient in 90 degrees shoulder abduction, 90 degrees shoulder internal rotation, and 90 degrees elbow flexion, and you would find the ulnar notch, and then you would tap on it with your index finger, and a positive test would be indicated by tingling along the ulnar aspect of the forearm, hand, and fingers. The neurological test I will be performing is for the musculocutaneous nerve, which dermatome is the anterior lateral upper arm, forearm, and the fingers. And you would test this bilaterally to look for any difference in sensation, and the myotome is elbow flexion, and you would have the patient actively flex their elbow. and the most common pulse site used for the elbow is the brachial artery.